Well, welcome everyone to tonight's Research Tuesday. I'd first like to acknowledge the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses at Roseworthy, Waite, Thebarton and here at North Terrace are built. It's my great pleasure to welcome you here. This is our last Research Tuesday of the year and it's an extremely interesting one. My name is Professor Robert Saint and I'm the Pro-Vice-Chancellor for Research Strategy here at the University of Adelaide. It's been a big year for Research Tuesdays, and as always our researchers have presented some fascinating topics, from keeping hearts healthy to improving beer through agriculture, from the mysteries of the universe to celebrating the achievements and the life of the great Sir Douglas Mawson. This series helps to showcase the incredible breadth and depth of research going on here at the University of Adelaide and its relevance to our world today. And tonight, our Research Tuesday Forum deals with a very specific topic that's touched the lives of so many, not just here in Adelaide, but right around the world. In fact, I'm told that tonight's forum was booked out very quickly because of the strong public interest in the topic. And I'd like to extend our apologies to any people who were unable to get a booking for tonight. But the good news is that this session, as with all of our Research Tuesdays, will soon be available as a video podcast on our website. Autism is one of those fields that's often misunderstood, not just by the general public, but also by many in the educational, medical and academic worlds. Tonight, we will hear from 3 University of Adelaide researchers about their work looking at different aspects of autism, which we hope will shed some light onto this very complex issue. Our speakers include our Professor of Human Genetics, Joseph Gex, who's from our Robinson Research Institute and whose expertise is in the underlying genetics behind many conditions, including autism. Dr. Neil Kirby from our School of Psychology, who has been working on video modelling and a social skills app to help improve the social skills of children with autism. And Mick Allen, a master's student in our discipline of anthropology, who's been studying how autistic people use theatre to express themselves. 3 very fascinating topics that I'm sure will give rise to many questions at the end of our session, questions I encourage you to ask. Tonight we're also extremely grateful to Autism South Australia for their support. The acting CEO of Autism South Australia, Louise Davies, has very kindly agreed to be our facilitator for this forum, and I'm sure we'll all greatly benefit from her knowledge and experience. Would you please join me in welcoming our panel for tonight and to start off our facilitator, Louise Davies.
Thank you. I think if I'd have known there was quite so many people, maybe I wouldn't have accepted. But now, I'd just like to invite the panel to take their seats, if you wouldn't mind. So, Joseph, Neil and Michael. And I'm going to give you a really brief tour of autism in 2 minutes or less, so that we just lay the scene for tonight. So autism spectrum disorder is a complex neurodevelopmental disorder. And people are born with ASD, although onset is sometimes recognised at different points during the lifespan. And we have usually 2 spikes in terms of diagnosis. So often we get a diagnosis spike around the age of about 4 years of age, and sometimes slightly earlier, and sometimes around about 7. It is a spectrum disorder, so it is very unique to the individual. And whilst there are 2 main areas, which I'll mention in a moment, around autism spectrum disorder, it is very unique, and the way that affects each individual is very specific. It's a neurological disorder, so the brain is wired very uniquely in each of those individuals, and it's developmental. So the milestones which each individual reaches may be at different times or in different ways, and it is lifelong. So the 2 areas which are affected by autism spectrum disorder are diagnosed now through the Diagnostic and Statistical Manual, DSM-5, are restricted and repetitive behaviours and social and communication and social interaction. And where those two areas overlap is, it is autism spectrum disorder. So that particular area is where diagnosis would occur. That is now commonplace that DSM-5 is used in South Australia as a diagnostic tool. Prevalence in 2007 was about 1 in 160. Now it is about 1%, which is 1 in 100. And in the US, it's about 1 in 88. It has been diagnosed in 2014, which is fairly significant. And there is a lot of work going on to determine prevalence in Australia. And it is more commonly found in males than females. In South Australia, there are currently about 8,553 registered for services in South Australia with Autism SA. And that's approximately 90 new diagnoses per month. So you can see the split there in terms of age groups. And the largest age group there would be the under 18 or those that are at school. And of course, those progress into the adult category. But those under 6 seem to remain around the 500 to 600 ages. That is increasing probably each year around the 6 to 7% on average. Last year, there were 1,080 individuals diagnosed in South Australia with an autism spectrum disorder. And I would guesstimate that there's about 10% of South Australians who don't register for service with Autism SA for various reasons. And we provide a number of different services for individuals with ASD, occupational therapy, speech pathology, psychology services, in school, at home, various services, and all those individuals would access those. Interestingly, cause is something that we often get asked as we do post-diagnostic appointments. And parents will often ask what the cause of autism spectrum disorder might be. And while we can't give a definitive answer, there are some things that we can say, okay, well, these things are proposed causes of ASD. The age of the father at the time of conception is one thing that we can track in terms of the number of instances of ASD increasing. So if 40 and above seems to be the age at which instances increase after. The fetal environmental exposure to things like certain drugs can increase the instances of ASD. And certainly genetics has been proven to be a link with one or more genes. And as you can see there, 70% of identical twins, if one or both, would have ASD, 31% of fraternal twins, and approximately 20% of siblings. So that was a very quick tour of ASD and just lays down some of the ground for tonight's discussions. And Professor Joseph Gex is now going to discuss some other issues around neurodevelopmental disorders.
Thank you, Louise. Thank you, Rob. Thank you, Joe, and the University of Adelaide for giving me the opportunity to present my experience with the aspect of autism spectrum disorders to this audience. Just before I start, I would like to tell you that my background is over 30 years in disease gene discovery. I started about 30 years ago at a time when the haemophilia gene was found, Duchenne muscular dystrophy or cystic fibrosis. These are big diseases. So I witnessed really the changes in this field and how we understand the heritable causes of these disorders. And I'm going to talk to you from that perspective. While for many years I was the describe as gene jockey, so the person who was jumping from a gene to gene, finding which gene causes what. I think now we're more becoming gene doctors, so we really try to understand what kind of variation, what kind of mutation in which gene cause what type of outcome, and how we can affect that trajectory to the outcome in a way that the outcome is not so severe. Oh. No, there is one slide missing, but let's go straight to the... So my background, on the first slide, what I had was pretty much an umbrella of autism, describing autism as a spectrum disorders. Many times, for many of you, perhaps the perception of autism is a single disorder. Autism is really a number of different disorders, and many of my colleagues, and including myself, we don't talk about autism, but we talk about autisms. That's the same, perhaps, if I compare it, not literally, to cancer. We understand that there are different cancers, they require different attention, diagnosis, different management, and different treatment. So we really need to look at these disorders of neurodevelopment autism is part of, from a kind of a similar perspective of extreme heterogeneity in terms of causes, the disease itself, and of course, better treatment and management. So my history is mostly in intellectual disabilities, and there are more than 1,000 genes now known. And in epilepsies, that's another area where we work on, there's more than 300 genes, and believe it or not, cerebral palsies, which have been investigated recently, which often present with autism as well, are also quite frequent, and there is genetic aspect to them too. So what we study really, and what I would like you to understand, is really the complexity of having a genetic mutation in our DNA, which then is presented in a different way in different individuals. We often have brothers, siblings, people who are related, and they have the same genetic mutation, but they can present with different disorders. And this is one of the spectrum. They can present with autism, learning and memory, intellectual disability, they can have a seizure disorder, other complex behaviors, but also can be non-penetrant. This is particularly interesting between males and females. Well, females are a lot more robust. They are protected. So in a way, females can cope with a lot more severe and larger insult before they develop disorder, and in this case, specifically autism as well. There was an interesting study published in the United States, this is a little bit of data, when they looked at medical records of more than 100 million people. And this is an interesting tree, which I will focus for you, so you don't need to try to read it. But these branches indicate a common risk, and perhaps joint or same etiology or same causes of these group of disorders which are sitting on the same branch. You know, if I focus a little bit more, you will see that intellectual disability, epilepsy, and autism really have most likely common root. Now, this complicates matters because we don't know which way the mutation will present itself. But I look at it from a different perspective, that it may actually present opportunity, how we can have similar or overlapping treatments for these quite different group of disorders, as far as we're going to identify the important stages, processes which we can target using our therapy. In terms of inheritance, I'm mostly talking about autism which is inherited. Of course, we don't know what proportion is inherited and what proportion is due to other causes, and there is ongoing debate about that. But if autism is inherited, that primarily can be recessive, so the boy's parents have the risk allele, but they are not themselves affected. Can be inherited as a dominant disorder that one of the parents can present. Can be X chromosome, which is a sex chromosome, and in this case the mother would not be presenting with the disorder, but the son will. Not every son, but 50% of her sons. But it looks like that the most frequent situations which we now finding out is the de novo event. So this is an event when our DNA is prone to accumulate mistakes, and as such, the parents don't have the mutation. The mutation happens anew, or de novo, as we say, in the affected child. And this is perhaps the most frequent, at least from the perspective of the current research course of genetic autism. Now, in terms of prevalence, you saw some of the numbers, and really they vary from 0.6% to 2% up to 2.6%, and that goes up. There are many theories why it goes up. You heard vaccination, immunization is one. Assortative mating, when people alike tend to marry, and if each one of them have a risk allele, that can be, of course, other environmental factors, or there can be also overdiagnosis, that we can better diagnose this disorder. And sometimes, I read in literature, can be augmentation of the diagnosis for the purpose of the access to the services. So it can be a borderline, but we push it into the diagnosis because then these people have access to specialized services. So there are different sort of speculations, and perhaps that can be discussed a little bit more. Boys are more frequently affected, about 4:1, you saw the ratios, but it can be up to 11:1 for Asperger's syndrome. The heritability, or in other words, the proportion of the variance which is due to genetic factors, it also can vary, but it's up to 90% in identical twins. The molecular causes are known in about 20% of cases currently, and they have been, this is based on large studies which were published about 2 weeks ago on 2,600 trios from the United States, or 15,000 patients also from the United States, 2 independent studies. There's one example of the number of known genes, about 171, which are the most scrutinized, but estimated to be up to 1,000 different genes. And of course, these genes can have different mutations, which can present themselves slightly differently. So that's complexity. But when we look at the individual regions in a human genome and DNA, then we go into thousands, and it becomes a lot more complex. So large studies are really required. Now, how much is this simple genetics, 1 gene, 1 autism disorder, or we need 5 risk alleles, and only then the disorder presents? So it's still a matter of debate. But the consensus is that it's probably a more complex disorder, and we need to have more risk alleles coming together to present themselves rather than one single insult. And in terms of early intervention and treatment, there is very little I can really offer from my reading and from my own work. But as I understand, there is no really pharmaceutical treatment of autism. There is some about stem cells, but there's perhaps still debatable how successful that is. Now, I finish with 2 slides. One, for your information, that there is a cooperative research center for autism in Australia, which was established about 2 years ago. For those who may not know about it, would like to get involved. Professor Andrea Whitehouse from the Telethon Institute of Kids in Perth is the person responsible for the genetic studies, and they focus on different aspects, diagnosis, education, and adults living with autism, which are often forgotten. So autism, CRC, you will find it through Google, or you will have access to this as a handout. And I would like to finish, again, with something different, which probably will lead to Michael's work, and that's the work of Rick Guidotti, who really put different perspective on looking at these rare disorders, which autism is. Individually, as a group, it's quite common. We're using photography and video really transform the perception of the public on these people which live with differences, which what it is. And it's really the way how he works, how he perceives these people is very different, which creates a lot more compassion and understanding. And I think that's what we need to do as well. In addition to the research, what we do and everything else, we just need to really be more compassionate with all these people who are a large part of our society. If it's up to 2%, that's a considerable part. And that's where I will stop and let probably Michael or Neil continue. Thank you.
Thank you, Joseph. Now, Neil, are you going to talk to us about some interventions and support? So, Neil's going to talk to us about eye modelling.
Thanks very much, Louise. This evening I'm going to talk to you about an eye modelling project that has been carried out at Autism SA and for children with autism spectrum disorder, and the evaluation of that program that's been carried out at the University of Adelaide. The people involved in this are myself, Neil Kirby, there's Julia Harries and Roma Gusher, who are members of the Wellbeing Research Unit at the University of Adelaide, and we've been evaluating this program. And I've included in this slide Meryl Perma, who works at Autism SA and has been responsible for running this program, and she's in the audience here tonight. The eye modelling project was funded by the Telstra Foundation over 5 years and was implemented in 2 stages. Stage 1 occurred from 2009 to 2011, and Stage 2 from 2012 to 2013. And as I said, the Wellbeing Research Unit at the University of Adelaide was involved in evaluating this particular project. Now, a group video modelling program was used with children with ASD across the ages of 8 to 16 years. And in each year of the program, there was also one group that also had an additional intellectual disability. Now, the video modelling program used 2 training techniques. The first of these is what is called Feed Forward, and it's designed to teach social skills to children who have not yet mastered those skills, and it involves providing instructions and guidance to help the child actually perform the social skill and videoing them doing that, and then editing out the instructions and the guidance so that the child can see themselves actually performing the skill independently and learn from that how to continue to do that. The second method is called positive self-review, and this is designed to improve the frequency and quality of social skills which exist but not in a fully developed form. And this particular technique involves filming the individual performing the social skill in a group situation multiple times, and then editing the film to show the best example that the child produces of the social skill so that they can see themselves producing the social skill correctly, learn from it and practice it. Now, the program involved 1.5-hour group sessions in which there were 6 to 8 children in each group, and these were held on Saturdays for 34 weeks in the school terms using 2 program facilitators, one of which was Meryl Perma, who is here tonight. Now, the sessions contained a number of activities, including a group game, filmed skill modelling and by the facilitators with instructions, a snack time, relaxation time, game time, and a DVD of correct modelling that the children could take of themselves, they could take home to watch and use as a basis for practice. There was also a parent support group that included some information sessions with information about how to support the child and in their skill development, and with opportunities to develop friendships and a network with other parents involved in the program. Now, in stage 1, which is from 2009 to 2011, there were a total of 76 children involved, again in groups of 6 to 8, and in stage 2 there were 48 participants, the ages ranging 8 to 16 in stage 1 and 7 to 13 in stage 2. Now, just an example of some of the social skills which were targeted in this program. For those with ASD, an example would be communication, which would be, say, taking turns in a conversation or joining a conversation. There was also an associated safety program which dealt with social skills related to dealing with issues like bullying, friendships, safe touch, etc. For those who had an additional intellectual disability, there was a modified program designed for their level of ability. Again, things like communication, saying hello, using the correct tone of voice, a safety program again and things like Safe Touch. And there was also an additional program on play schools, taking turns and joining in play. Now, the evaluation and method involved asking parents about their child's social skills, so we did not actually assess the children's social skills directly, but we asked the parents to comment on those social skills. This was done at the beginning of the program, before it started, at the end of the program, and 3 months after the program to assess the maintenance of any skills that have been developed. The interviews involved asking the parents to comment on the social skills of their children, but we also used a quantitative social skills measure. And in the first year, we used a measure called the Social Skills Rating System, which asks parents to rate their child on various aspects of social skills, so you can get a score of their social skills. And in subsequent years, we used a revised version of this measure, which was developed and became available, which was called the Social Skills Improvement System. Now, we examined changes as a result of the program, both in terms of the total score on this particular measure and also the subscale scores. And the subscales include, as indicated in the slide, areas of social skills like communication, cooperation, assertion, responsibility, empathy, engagement, and self-control. And the ones that you can see asterisked in the slide there, that is communication, engagement and self-control, were the social skills that were particularly targeted in the training program. Now, if we have a look at the results of the Stage 1 research over the first 3 years of the program, what's shown here with the yellow column is the mean score on the social skills scale before the program. The pink column shows the score at the end of the program, and the green column shows the mean score 3 months after the program. And you can see in year 1 that's been improvement in the mean social skills score, and that's been maintained 3 months after the program, so showing that those social skills have been maintained. In year 2, there's evidence of improvement, but there are not enough children in those years showed improvement for it to be statistically significant. In year 3, however, there were improvements, and you can see that after the program and 3 months beyond the program, there were significant improvements in the social skills score. Associated, of course, with this statistical significance are variations in the number of children who actually showed improvements and the extent of those improvements. So not all children improved, and not all children improved to the same extent. Now, the Stage 2 part of the program included an innovation, which was the development of an iPad modelling application for the program, so it could be presented on an iPad. And there were 2 parts of the project in Stage 2. First, a group-based program, which was the same as in Stage 1, and then a second outreach program, which was designed for parents of children who lived outside of the metropolitan area and who were unable to access the group program. Now, both of these parts of the program involved a homework component involving practical social skills exercises to be done at home with the parents. If we look at the Stage 2 results, you'll see that they're very similar to Stage 1. For the year 1 and 2 of the Stage 2, you can see that there are improvements immediately after the program in terms of the blue column, and that these are maintained in the green column, showing the evidence of maintenance of these skills 3 months after the program. During both Stages 1 and 2, we also asked teachers of these children whether they had noticed any improvements in social skills in the school environment, in the classroom. And you can see there that in Stage 1, 49% of the teachers commented on improvements in the social skills of these children, showing that the skills were generalising beyond the training environment to the school environment. In Stage 2, this percentage increased to 72%, showing that Stage 2 achieved a greater generalisation of these skills in the school environment. We also asked parents for their observations on any generalisation of these skills, for example, in the community, and 76% commented on generalisation in Stage 1, and this rose to 94% in Stage 2, again indicating that these skills were generalising beyond the training program. You can also see in the Year 2 results that both the blue column and the green column, showing the after the training results and the 3-month follow-up, that both of these are in the average range of the social skills for this particular scale. And this is quite, I think, a remarkable achievement of the training program to elevate quite a percentage of these children into the average range for the skills that were actually targeted in the program. Now, the particular skills that were most developed varied from one program to another. And for example, in the group-based program in stage 2, engagement seemed to be the skill that was most developed or achieved most improvement, whereas in the outreach program it was communication. But again, as in stage 1, there was variability in the results, so not all children improved in their social skills and not all improved to the same extent. We also asked parents to comment on any benefits of the program, and benefits that they commented on for their children were improved social skills, developing friendships, improved self-confidence and self-esteem. But again, this was less for some children than for others, and less particularly for children who were not as keen on being in groups as others, and those who didn't particularly like watching themselves on video. Parents also noted some benefits for themselves in this. They learnt strategies from the homework for managing behaviours and teaching social skills, so they improved themselves in terms of their management of their children and in teaching them social skills. Also benefits from the parent network which was set up, and also they reported an improved understanding of ASD by family members. Just one comment on the benefit of the parent network. One parent told us that she was able to arrange the first sleepover for her daughter as a result of a friendship that was developed within the group and that she made with the other parent in that support group. As far as recommendations for future research, I think the next stage is to try and implement and evaluate this program in other environments, particularly in the home environments and in the school environments, and I think perhaps optimally in both the school and home environments. So if this was done simultaneously in the school and at home, I think it would have the maximum benefit. Associated with that is determining the type of support that will best enable teachers and parents to maximise the benefits of the program. Also, I think there's a need to research the different social skills training programs for different parts of the developmental stage of the child, so that one might have a training program in early primary school, perhaps another social skills program in the transition from primary to secondary school, and then another at the end of secondary school, with each program concentrating on particular social skills important for that particular stage of the child's life. At the end of the slide there, you can see there is a website, www.imsocial.org.au, where you can find more information about the program and also about the research. And what is needed now, I think, is more funding to enable this very exciting research to be continued. Thank you very much.
Thank you, Neil. We'll talk a little bit later about I'm Social. Not that I know anything about it, of course. All right. Michael, it's your turn.
Good evening, ladies and gentlemen. Thanks for coming, and thank you for the university for asking me to speak. I come at this topic from a slightly different perspective. My background is actually as an actor and a director and a producer, so I come from a performing arts background. And I'm doing a master's in research in anthropology. What got me onto this is a performance I saw of a company who are what we understand to be the only autistic theatre company in the world, that being that everyone in the company is on the spectrum and they create all their own work. I think one of the things that attracted me in the first instance was coming from a background as an actor. Having been trained as an actor, we're trained in all sorts of non-verbal social communication techniques, body language, winking, things like this, all the taken for granted assumptions we have about communicating with each other. When I went and saw this company, I was amazed. I was watching actors who, some actors didn't like to be touched. Some actors didn't look at the audience, they looked at the floor. Other actors had different variations of things which should, to my background, would be an inhibition to being a performer on stage. And yet here was a company that was performing work which was creating and engendering an emotional response in their audience. So this is what got me onto my research. I wanted to know more about this. I think there's many aspects to this, obviously, but I think one of the ways into it was the fact that, as we've heard before, there are certain taken for granted assumptions about people on the spectrum and their ability to communicate and the ability to socially engage with others. I think what I found in my research is that the concept of a theatre performance, the concept of a play, what it does is it suspends those everyday frameworks or structures that we come to understand people. So in terms of, just here is an example as we speak, by definition of the space that we're in, the three of us up here have some sense of authority over what we're talking about. People listen to us. I think what the actors are finding in this company is that when they get to perform on stage, for some of them, the first time, people actually listen to them. And people actually interpret what they're saying. And the theatre is a space where you can take an abstract idea of an everyday meaning and reinterpret it on stage. And you can create a level of communication that transcends the everyday communication and frameworks that people understand each other by. Some of the examples of how this works are in some of the feedbacks that audience members have had with the company over the years. There have been examples of esteemed academics working in the field who have come up to the company after watching one of their performances, and there's one anecdote that the company like to bring out whenever they can, which this esteemed academic came up to them. He said, "I've been researching autism for 20 years. I learnt more about the experience of being on the spectrum from watching your half-hour show than I have from 20 years of research." I think that's one of the other aspects of performing and this particular company, is that they embrace a sense of agency and identity. There's a certain amount of activism involved. They are aware that they have a captured audience for a time being, and that they don't have to be spoken to or spoken about in any other kind of framework, that they can take and interpret their universe that they live in a theatrical form that is open and accepted by the people who are watching it. And from there, communication and dialogue happens. Another example was there was a short scene. It was simply a domestic representation of what happens around a kitchen table in the morning before we go to school. And one of the parents of one of the actors who was in that scene said, and this brought a tear to the actor's eye, which was also unusual, is that he understood more about his daughter's experience and what her life was like from watching that 10-minute scene than he had from his entire life with her. I think that shows the power of the communication that this particular forum has for these people, that they can suspend those everyday relationships, and people can view an actor in telling a story and interpret it, rather than try and talk through means of medicine or other frameworks and such. This being a performance element, I do have a small scene that I wanted to show you from one of the shows that they've done, but I just wanted to touch on quickly some of the other aspects that I've seen. Is that traditionally, I guess, a taken for granted assumption is that people on the spectrum have difficulty registering empathy or registering the other point of view. It's often termed as a theory of mind. My experience with researching this ensemble of actors is that that's not necessarily the case at all. There was one particular example where they were playing a theatre game where you simply two actors stand on stage and one person says a phrase, and the other person repeats the phrase, and it goes back and forth. And the idea is that you top the energy of the other person and the intention of the other person. In this particular case, the phrase was an abusive phrase that they were using, and the scene got very, very heated in the room, and everyone started to feel a little bit uncomfortable, like we shouldn't be here. At the end of the scene, one of the actors turned to the other one, he said, "You're right, aren't you? You know I'm just acting." And I think we all kind of registered that there was something going on there. So there are other examples as well. I've seen, there was a scene where the director asked the actors to pretend to be an autistic child. And the actors got up on stage and they pretended to be autistic. Now that's a unique phenomenon in anthropology, the idea to be able to phenomenologically re-experience someone else's point of view. To be able to take yourself out of your own experience and present another point of view. Particularly interesting when the actor was already on the spectrum. In some respects, they didn't have to act. They just had to sit there and do their thing, but they acted autistic. And it's really interesting to watch their interpretation of what autistic people are when they're on the spectrum. It's quite funny. Really funny watching them do neurotypical behaviour as well. But I'll move on and I'll show you a little scene. This scene was developed as part of the Ensemble Creative Development process. This particular performance was the first time it had ever been performed publicly. It's since gone on to be incorporated in a show that they've developed called The History of Autism, which has been picked up by the Come Out Children's Festival next year. So if you're interested, you can go along and have a look at that. They're also working on a new production in 2016 as well. But I will click on here and you'll get a sense of this idea of being represented in a particular frame and how that can be challenged.
Hi, I'm a neurotypical, or NT.
Hi, I have Asperger's syndrome, also known as AS.
I function quite well in the world and meet all of society's standards.
Unless I have help or support from other people, I find it quite hard to function in the world. And also, I need help in order to be socially accepted.
I have friends, a job, a house, a wife and kids, everything I deserve.
Most of the time, I miss out on my life as father because of my difficulties.
I enjoy my life.
Having enjoyment is a day-to-day prospect for me.
In social situations, no one thinks I'm any different from them.
I struggle with social skills, but sometimes those are just potluck for me. Sometimes I'm weird, other times I'm refreshing.
Sometimes I feel like I'm boring.
That is one thing I am never accused of.
More and more I feel like my life has no meaning.
My life has all the meaning I need.
I don't always feel fulfilled.
As long as I have what I need, I'm always fulfilled.
I can never remember my wife's birthday.
Never forget a fucking thing.
I constantly feel I'm trying to get society's approval.
My life is me.
I have lots of interests, but I'm not an expert in any of them.
I'm an expert in a few things, and I'm an expert in all of them.
I'm fairly stable.
I don't divert from my routine.
Often feel I have to lie to everyone.
I say what I think.
My life seems like a constant series of pretending.
Never pretend. Don't even think about it.
There is very little happiness in every area of my life. When I'm in bed with my wife, I have to think of someone else to get the job done.
If I try to have sex with someone, I probably spontaneously combust.
Entire days about providing everyone in my life what they need.
I really think about people unless society tells me to, like say a birthday party. Otherwise, I'm just not interested.
I feel like nothing defines me.
I have lots of things that define me. Like this guy.
He's right, Leo. I have higher functioning autism on HFA. That means I'm close to becoming more autistic than this gentleman. However, I function more, meaning I may need a little bit more support than this guy. But hey, I get through, ain't that right?
We're not that different, and we both see the world differently.
I only get to see the world in a single dimension, and I often wish I was dead.
Whoa, I think you're just crossing the line there. I mean, I've had that problem too in my daily, but not in my daily life. I mean, once I get help, and by that people are told to accept me, I'm fine with it.
If I try to tell people how to talk to me, I'd get told to grow up.
Sucks to be you.
I'm beginning to believe that, yes.
We're both incredibly unique people who contribute to the world so much just by being alive.
Great.
Hi! I'm HFA too.
What?
Yeah, I have the same diagnosis as this guy, but it affects me differently. I have my own separate individual personality. Oh, what makes me so different is that I have a speech delay that has been censored for this advert.
Fantastic. I'll have to pay for elocution lessons.
I always have an incredible memory like AS, and I'll always remember your name, even if it was 5 years ago, for 5 minutes.
Yay.
Hi!
Oh, come on.
I'm autism. You can call me A. I have a learning disability. I'm usually non-verbal, but I can see the world in a way you can only dream of.
Look, this is ridiculous. How many more of you are there?
I think you know, otherwise an expressive developmental disorder not otherwise specified, which basically means no one knows what the hell I have, unlike the others on the space.
Well, that's just great. You're all fantastical. You're all amazingly individual. You have all these benefits. You have a clear sense of identity and you're free to be who you are. Whereas my life is all about wading waist deep through a quagmire of identity crushing, soul destroying, mind numbing crap!
Well, it's going to be easy having neurotypical disorder.
Well, thanks.
All right.
Well, there you go. That was exciting. I've seen the history of autism. I find it fascinating to watch the whole thing. So I don't know if anybody else has seen it, but it's well worth going to visit if you get the opportunity. Now, I get the opportunity to ask you some questions before we throw it open to the floor, so I'm glad about that. There's just a couple of things I'd like to pick up on, if you don't mind. Joseph, this is always a bit contentious, so I'm going to ask it. Around vaccinations, you mentioned that vaccinations could be identified as a cause, potentially, of ASD. And there's always been a big debate about this, and a lot of research has gone into whether that's true or not. And then, so I'm just going to ask you, what do you know?
Well, I asked for that question, so I better answer it. As far as I know, we ourselves don't do these studies, but we have been working with disorders which can be precipitated by immunizations using the MMR immunization. It's about 6 to 9 months. So as far as I know, the studies which followed, of course, the perception that this type of environmental trigger can cause autism showed that there was no correlation, because the incidence of autism is going up, but really the numbers of people being immunized stays high, and it's not changing. So there is, though, that's also another aspect to it, and that's from our own work and work of our colleagues in epilepsy, where people usually begin to have seizures about at the time when the vaccination is administered. And of course, that was the cause of so-called vaccine encephalopathy. But what this research found, that these people would have developed that seizure disorder irrespective of the vaccination. It is just a coincidence of the timing of the vaccine, the fact that there is a slight fever coming after vaccination as a reaction to the virus. And that coincidence sometimes causes sort of precipitation or the onset. So in a way, there is, for some of these, we can speculate there might be already inherited predisposition to this, which can be revealed at that time by immunization. Well, that's at least the case for the vaccine-related seizure disorder. I have not seen anything similar for autism. That's just a speculation as far as I can say, and have understood the research. There is no support for the fact that vaccines would precipitate or increase the prevalence of autism in the population.
That's what I understand too, and I just wanted to check to see if that was your understanding, but there may be a onset kind of issue. Okay. Now, and also interestingly, DSM-5 has kind of put all autism spectrum disorder together, so there's no kind of specificity anymore around, which from what you were saying on your first slide that wasn't there, seems a bit odd when we're saying that actually ASD is really specific and different. So what do you think about that?
I really can't comment in great detail on the diagnostic sort of approach to this, but we start to understand really much better that autism is a spectrum and it's a continuum. So while at some stage it was good to really put it in different boxes, maybe now we start to understand that there is a continuum and there is one group of disorders. Perhaps from a genetic perspective, we can really distinguish two major groups, and that's one with learning and memory problem or with intellectual disability, and one without. Now, interestingly, it looks like that, again, from the genetic perspective, the etiology, the causes of autism with intellectual disability are going to be different, or they look different to those with individuals with autism without learning and memory impairments. I guess it's a suggestion from the genetic investigations which needs to be followed, but it looks like that would split the group. But otherwise, I think the new diagnostic scheme is probably appropriate given our better understanding how complex the disorder is.
Yeah, it is really complex, and it might give us a better chance of appropriate interventions and supports. Neil? I think it's fascinating, the research that's been done in terms of the eye modelling, and obviously there's been some significant gains. Do you think there's any specific elements of the programme that have worked really well?
It's a bit difficult to say because those elements are all combined in the program, and what we're assessing is the combination of the group work, the video modelling and the training that's being provided by the trainers. So I think all of those components are really important, but in order to tease out those particular things, you'd need to do more research to look at each of those components sort of separately. I'm not sure whether Meryl would like to make a comment on that aspect of the training, because she was actually involved in doing it. Do you want to say something? This is Meryl Perma, who ran the program and who's probably more of an expert on that.
I think from personal experience, what was very beneficial was that we have included the parents in the intervention, so it was not just us, the group facilitators, teaching the children the new skills, but we've also been able to support the parents and teach them on how to use the video modelling at home as well, and the parents felt very supported in that process. Yeah.
And I think Joseph's questions led me to ask this question. Who was the intervention, who did you implement it with? Was it Asperger's? I know the diagnosis has changed, but was it Asperger's syndrome? Was it intellectual disability? Because that might have an impact on how successfully the results were achieved.
Okay, so we had two separate programs. One was for children with an intellectual disability and one for children without an intellectual disability. And we have obviously different targeted skills and a different way as well of teaching the program. So for the children with an intellectual disability, we've used a lot of the positive self-review because getting those children to do role plays was a lot more difficult. So we got them to engage a lot more in group activities and filmed them engaging and using the skills that we were targeting for that session. So that was a big difference between the two.
And did you find a difference in the results, or were they both equally as positive? Was that putting you on the spot because you haven't got them with you? Was there a difference in the results for the intellectual disability group and the non-intellectual disability group, or are they both?
I haven't got the results here, but... Sorry, thanks. I haven't got the results here in terms of the difference between intellectual and those. Obviously, they were at different levels. I think the point that was made about this being a spectrum disorder is there's a very wide variation in the skills that are presented by the different children. So people from, I mean, there are some without an intellectual disability did not do as well as some with an intellectual disability. Vice versa. Overall, I don't think they did quite as well, but they still showed improvements in the program as well as those without an intellectual disability.
Yeah, I think from a group facilitator's perspective is that we felt that the children with an intellectual disability were more engaged in the video modelling because they really loved watching themselves, and so they would watch the video model over and over and over again. And I think that for that group of children, the video modelling was a very good technique to use.
Excellent, thank you. And Michael, I'm not really sure what question to ask you because I've been quite involved with Company Out because they started as a social development group for Autism SA, and then they have moved to be supported by Tutti because we believed that actually they needed a more specialist support in terms of the... Do you think that's actually supported them to develop more as an autistic theatre company?
Yeah, I think so. I think there's a certain amount of autonomous agency that the group have started to embrace through the work. It's evolved from its early days as just some workshops with Autism SA, and then slowly they brought in an artistic director who is on the spectrum as well, but has gone through a professional acting course and learnt all those skills, and so he brings that with them. And as they've progressed and learnt more skills, they've realised that they have this sense of agency that they can affect and communicate with the world in a way that probably they haven't been traditionally able to through the standard forms and groups and organisations and that sort of stuff. So I think going out more solo into the world as a artistic enterprise has it's scary for them, definitely, because they're in a different mix now. They have to compete for grants against other arts organisations, and you know, as Neil mentioned, funding's dwindling everywhere, so that becomes more and more competitive. But they're also they're opening out and becoming more engaged with the artistic and theatrical community. The project they're working on now has a writer and a director and a dramaturg as well. So they're really starting to engage with other artists in the community and form these bonds and ties, which are broadening their exposure and their ability to find ways of communicating their ideas.
Excellent. And I know traditionally a lot of the focus has been on autism, so the plays and things that they've done have had something about ASD in there. Are they thinking about taking a different tack, or are they going to continue?
Yeah, I think they are. I think the sort of vagaries of grants is that they have to sort of trade on their autism for a while, because that's kind of what's getting the money. Yeah. And I guess that's part of what I was saying before, that their identity is structured by the organisations and groups around them in the first place. But I know a project that they've wanted to do for years that they're working on is the autistic version of A Midsummer Night's Dream, which I think would be fantastic. Yeah, it would. Because it's all about, a play really is all about the interpretation of the words to the stage, and that process of interpretation is what makes the art, I suppose. And
Yeah.
so that interpretation coming from an ensemble with a particular outlook of the world would be a very unique production.
Oh, and I don't think they should lose that. I just know that the things have been around the history of autism or how the autistic mind has worked. So I'm just wondering if they're moving away from that to something that was more kind of artistic with an autistic.
Yeah, it's a double-sided coin. They often talk about that they don't want to be didactic. They don't want to get up and teach everyone what it's like to be autistic. They don't want to be teachers per se, but they also recognise that they are in a position where they can communicate their worldview, their perception of the world, and this is a unique opportunity that they can do it. So they kind of cross the line a little bit between that artistic representation and the advocacy aspect of it as well.
Lovely. All right, I guess it's time to get some questions from the floor. All right, there was a first hand up there in the middle at the furthest person away there, Joe, sorry. Just...
Good evening. A question for Professor Joseph. Does autism spectrum disorder follow on racial lines at all, or is it the same for, say, African Americans versus Africans in Africa and Chinese in China and people who've lived in Australia for a long time, or is there no difference at all, or the Indigenous Australians?
That's a very good question. I mean, the historical answer would be we are all different. We know it from studies of intellectual abilities that there was quite a strong racial bias, and some of it still survives. And these are usually what we call ascertainment bias, because these populations were preferentially investigated with a bias. Given the fact that the most of the mutation is de novo, that affects everybody irrespective of the color of our skin or the size of our body or the curliness of our hair. So along those lines, and that's how I understand from these epidemiological population studies, that the prevalence is not statistically different. Of course, there is the ascertainment bias, how these different backgrounds or different countries deal with approaching this diagnosis of autism. Of course, that depends on the quality of the healthcare, that depends on the environment, the quality of life in general, how they can identify. These are complex issues which sometimes can skew sort of the outcome and push it into one extreme or the other extreme. But I'm pretty confident that time will just tell us that there are no differences based on race or colour of the skin.
And there are certainly cultural issues in that regard, so some cultures may not identify ASD. So certainly we are aware that Aboriginal Australians, it is under-identified in that sector.
Good evening. I'm in my 70s, and only 18 months ago I was diagnosed with Asperger's syndrome and bipolar disorder. Wow, I now know what my life's all about. Absolutely. And the finishing second part of that question, I'm a little bit bemused that we've done away with the term Asperger's syndrome, and we are now classifying people like myself as being autistic. That doesn't make sense to me. Thank you.
Asperger's syndrome, the phrase will still remain. It's just now that obviously with DSM-5 there will be no new diagnoses of Asperger's syndrome. That's all. So you can be proudly Asperger's.
I have cerebral palsy.
Get your microphone.
I have cerebral palsy, and Professor Joseph over there, I am particularly interested in longitudinal education of people with autism. I was wondering if you could give me more information.
Thank you very much. I probably, from my own perspective, I don't do this type of work. I think the best would be probably to get in contact with the Autism CRC. It's one of their main interests to look at adults living with autism and other comorbidities, like in your case. And they run longitudinal studies, how sort of adults integrate into society. They really look at their needs and the needs on their environment and their families. So I just only recommend probably to get in contact with Professor Andrew Whitehouse and Autism CRC. Google will find it very quickly and very easily, because the power is in numbers. Investigating small numbers can give us misleading results. In this case, when it's concentrated perhaps through the centre like the CRC for autism, that would be my best recommendation, probably to get involved and get help through them.
In recent years, statistics are showing that autism is on the increase, but is it because better diagnoses are being made? I know children who are still not being diagnosed because their parents don't want them labelled. They recognise that they probably do have autism, but don't want them labelled. And also I recognise adults with it who, some are not aware of it and others don't want to be labelled. But is it really because we're now a lot better at diagnosing that the statistics are rising?
I think that's partially it. Yes, I think that we certainly, I've noticed in the schooling sector, for example, that there has been an increase of teachers and in kindergartens they're much better at identifying individuals with ASD. Then, of course, it is definitely down to parental choice as to whether they pursue a diagnosis. So I don't think it's the only reason, but I do think it is one of them.
I just wanted to jump in on that one, and probably going back to the race question a little bit too, is that autism is initially, well, really we only have a diagnosis that goes back about 50, 60 years when it was first identified. So, and in that sense, it was really broad. As we've had more over the years, more research done, we've been able to narrow that diagnosis down. But I think you mentioned a very interesting point, is that there's initially a social relationship with anyone on the spectrum, and the other relationships that are around that sort of determine what path that goes down. There are some people who embrace the label and really own it, and there are others who reject it. And I think that there's this element of this of how autism is perceived socially, which in turn can have an effect on how we diagnose or how we treat or how we understand or identify people on that spectrum. I was doing a project at a school a while ago on transition from primary school to high school with people on the spectrum, and there was a teacher there who openly admitted that his entire understanding of autism had come from what he'd heard, what people had said to him. He'd done no research, he'd been to no seminars, he'd had no training in autism at all, but he was a teacher who was responsible for even suggesting that this child might need to be going diagnosed, because his perception, his social perception of what autism is, was immediately affecting how he looked at that child in the first place. Thankfully, he's learned a little bit more about it now and has a different approach. But I think that the initial understanding that someone might be on the spectrum comes from that place of they are not behaving normally, they are not behaving as they should socially, or these kinds of parameters or frameworks, and that can also have an impact on how the missing 10% that you suggested, you know, the people that aren't maybe on the spectrum but haven't been identified, and these things as well.
Thank you. I'm just in the middle of doing a part-time degree in counselling and psychotherapy, but it's also led me into some extracurricular studies into brain plasticity. And I'm just wondering whether the panel can tell me whether there's anything in reference to autism that's being helped in this area, especially to do with brain neuron, because I've actually read that there is, but I'm just interested in your opinion and whether you know anything about this study and how it's helping people with autism. Thank you.
I'll try again. I'll try to understand. There is a research group here at the University of Adelaide specifically interested in brain plasticity as a consequence of transcranial stimulation and application to different types of disorders. Certainly, that's like with the exercise, our brain reacts to activity positively. What that means that there are networks formed, new connections are strengthened, and as a consequence, there is better communication. Now, to what extent this can help in autism, I can't comment generally, but it definitely helps in patients with learning disabilities and other forms to some extent, simply because the causes of many of these disorders are actually right there, that two cells in our brain or the networks cannot be formed and the memories cannot be retained because simply the connections are not strong enough, they are weak, they happen and disappear, and certainly these stimulations strengthen them significantly. So I would say, yes, there is a room for it, but the most difficult question is to what extent actually that's going to change and in what type of autism, whether it's going to work for more boys or more for girls, because there are differences in plasticity between men and women, because that's to some extent determined by the hormones, which also have been found to play an important role in the etiology of autism.
My son has just recently been diagnosed with, positive for, I think it's MTHFR gene. And I wondered if you could tell me more about that, and given that there were so many gene mutations, whether that information is useful in isolation or whether we need to know more, and how would we go about finding whether there are more he has more mutations?
This is a very good question. I can't comment specifically on the MTHFR gene, but I can tell you that we work on a few genes when there are 100, 150 people internationally diagnosed with mutations in that gene. They form patient-parents groups. We interact with them, they fundraise, and we have focus-supported research, specifically working on those disorders. Knowing the cause is a start. It's not a solution always. It's a first very important step. And it's the collective knowledge of the parents and the specialists and the international community which put together the clinical presentations, the sort of the trajectory of the disease, together with the experience, sometimes by trial and error, how better manage the patients with these specific mutations in specific genes. Along those lines, it's fantastic that we have a global communication facilities where these people can talk to each other, they can exchange their experience in a very friendly way and almost immediate. And I think that's the best way how to push the scientists, the governments, to really focus and invest. So I'm sorry, I'm answering in a more general way, but I see the diagnosis hugely important, but the follow-up is as much important, because it's what we want to achieve is not a diagnosis, we want to achieve better management and treatment at the end.
Thank you.
Can I just comment on some of the questions that have been asked? I think the important thing is not to think about diagnosis and whether there's a genetic cause as if that means nothing can be done. I think this is a problem with intellectual disability, the assumption that once there's a diagnosis of that this person is incapable then of learning. We don't know unless you try. And that's why I think these training programs are very important. People can make real gains. It may take many years for some people to learn these sorts of skills, but one of the things that happens with intellectual disability is that it's mostly a phenomenon across the school years, where it becomes very obvious that they are not doing as well as their peers. But often people with moderate, mild disability, intellectual disabilities, as they get older, they disappear into the population because they gradually acquire the social skills and the work skills and the other sorts of skills they need to live. And I think those skills can be facilitated by the right kind of training programs. So I think there's a real danger in diagnosis that people will give up on trying to improve these things. These sort of improvements are not made immediately. There's no magic cure to these things, but perseverance over a period of time, good educational systems, good training systems can make a huge difference to people's lives.
Thanks, Liam. And ARM Social's really good for that, actually. The programme that's online that was being developed for me. Just a little plug there. So, yeah. Sorry, next question.
I am a human geneticist. I want to congratulate Michael Allen. Indeed, theatre is the only chance to have a say for the genetically distinct persons. Thank you. And now I have a genetic question. Advanced paternal age is associated with increased risk for schizophrenia and increased risk for autism in offspring. Now, autism is diagnosed in childhood, and schizophrenia is diagnosed at age about 20 years. What percentage of autistic children turn up schizophrenic later in life?
Very good questions. I'll take the first one first, and that's the paternal age. That's an important issue and perhaps controversial. We have children later and later in our life. And we have come to realize now, since we have the sequence of human genome for about 15 years, and now we can sequence it in you and me for about $1,000 or less. That's just to do it. So we can read these 3 billion, and we read it in a rate of about 1,000 to 10,000 people a day internationally. So it's happening really quickly. So we're getting a better perception of the variation and how happens and what happens. Now, if you compare a 30-year-old father to a 50-year-old father, there are 10 times more genetic mutations in a sperm of a 50-year-old father on average. A 50-year-old father would have at least 3 times, or 2.2 to 3 times, higher risk of having a child with autism than a 30-year-old father. Now, fathers are the risk primarily because of the way how the cells are generated. They go through many divisions and they have a more sort of opportunities in that sense, negative, to accumulate this genetic mutation. Mothers, of course, pass on other genetic risk, like in case Down syndrome. Maternal age is very important, so it's not only the fathers to blame, I'm just standing up for them. So there is a risk. Whether this is an important factor in contributing to increased incidence of autism and prevalence of autism, it's again debatable, but we need to be conscious of it, that advanced paternal age brings increased risk, not only for autism, but also for schizophrenia. Now, comorbidity of schizophrenia and autism, I'm not aware that this would be significant or highly significant. Comorbidity of autism, intellectual disability, epilepsy, cerebral palsy is considerable. But with schizophrenia, even on the chart which I showed you, schizophrenia was completely on the other branch. So even from independent investigations of medical records of presence of schizophrenia with autism, from that populations of more than 100 million people, was definitely not significant. So I would say it's not very high.
Yes, when my son was 2, he had a ear infection and had some antibiotics to clear it up, and that seemed to be when he got a lot worse. Do you think that would have something to do with it? I remember on a TV show on the ABC about there was a common link between having antibiotics and then developing autism.
It isn't something that I've necessarily heard of, but 2 is around the time that language starts to develop, so it's something that is noticed at around the age of 2. But I don't know if anybody's got anything else to add.
I'm really not aware of any studies looking at this specific association. I just can comment on it that, of course, if it's not a coincidence, and it can be coincidence because that's the time when usually autism is frequently diagnosed, as far as I can comment on, but I can ask Neil. So that might be a coincidence, but I don't really see any really obvious or even suggestive link of a trigger by antibiotics. Unless it is a stress. Certainly in epilepsies we talk about it, whether that's the fever that can generate a stress to the organism, which then can unmask the genetic predisposition to precipitate a little bit earlier. So that would be the scenario of an environmental trigger revealing the pre-existing genetic predisposition to that disorder.
Thank you. Our son is 12 years of age. He was diagnosed with autism at just under 3 years of age. And we did do a lot of ABA initially without much benefit at all. I don't think that he had much benefit from it. Now he attends a special school. He has been right through his life. He has got autism and intellectual disability. And my question is from Dr. Neil Kirby. It was a very exciting project that you have done. I didn't hear about this project being advertised at all. We are members of Autism SA. It wasn't, I don't think I have not ever seen it being on any of the emails. Would you be keen to incorporate it as a pilot project in any of the special schools? Because our son takes his iPad to a school, and he loves looking at himself whether swimming or riding a horse or something like that. And certainly this would be very interesting and could be of great benefit to him. So would you be interested in involving it at least in special schools for a start? And parents are always willing to fund. We don't have to get funding from anywhere else. So if you'd be, that'll be great, I think. I never heard of this program ever before this today. So,
me to take this one, Neil?
Thank you.
Okay. The I'm Social website is up and running, and on the website, the 34-week programme is available. It's available to families to utilise at home, so you can log on and log in, and it's free, and it's available for families to utilise. It's also available as a group programme, so schools can access that to utilise in the schools. And in fact, the Special Schools has taken that as the programme and is utilising it as the whole programme, assisted by the lovely Meryl, to run that in the school itself. So yes, the school can take the programme and utilise it within the school setting, and they can ask Meryl to assist them to get it up and running. There's absolutely no problem with that. And if they want to phone Autism SA and ask how that they utilise that, then there's absolutely no problem. But obviously the school have got to be willing to implement that as a strategy within the school setting. So, but we're more than happy to assist in any way that we can, because it has great results. So yes, we're more than happy to do that.
Can I just comment on the schools aspect of that? I think at the end of my talk I said that I think the next development is to try and have this program developed in schools. But I think if you want to do it properly and have it most effective, you need to do it with research. That is, you need to find out what is the best way to use the program, what sort of support teachers need in order to get the most effect out of these sorts of programs. So I think there's a real need for research on this, but definitely I think that the greatest potential for this kind of program is to have it implemented in schools in association with the parents, so that the children get the development at schools, in the schools of the program, and it's supported by the parents at home. But they again need to have assistance in being able to use the iModelling app, for example, most effectively. And that's one of the things I haven't been able to comment because we didn't have enough time, but one of the things we found in the outreach program is that a lot of parents said they found it very difficult and they would really like assistance in how to use that app most effectively.
Good evening, everyone. I have a son who is now 8 years old. He's going into the local primary school. As I was trying to reach a voice there that 3 hours per week for my son, it's definitely not enough. And I could not get any more because he was already on top of the hours at school. So the question is, if we don't acknowledge, you know, that more and more children are having autism and are diagnosed, how we're going to help them, because the most of the days they spend outside of the home. And another question is, because it's a talk now about NDIS and the help that's available for us. So I'm just wondering, you know, how much, what help and how much we can give our children, but not overload them. Thank you.
Can I just say, with respect to the program in schools, I did also mention, I think in the last slide, the need for a series of programs across the developmental years. I think the earlier that you can understand the difficulties, the earlier you can start training and providing assistance, the more effective it's going to be. It's not going to be effective to take someone at the age of 20 after they've experienced 10 years of developing strategies to avoid social situations and then try and teach them those things. The earlier you can get in with the kind of training and continue that across the developmental years, the more effective they're going to be able to function when they get into the adult society.
I think the NDIS question's an interesting one, and you're right, it's essential to build capacity without overloading the individual bit. It really does depend on the individual and the capacity of you as a parent to support that as well. So I think it's really something that you have to judge at the time. And as you go and see your planner, which will be the next step as that rolls out, then it's something that you are going to have to look at the goals. And if it needs modifying, then you need to modify it at the time and go back and say, you know, this is too much at this moment in time. We need to modify that particular plan. And that's okay. You don't have to do everything all at once, but it needs to suit you and your child, which is the important thing. And probably the last question.
Just very quickly, coming from an educational point of view, it's just going on from what that lady's saying. Funding is getting cut more and more, and I'm in a college situation, and my time has gone from 2 people full-time, and I'm now half a day a week to support all our children with special needs. So, and they're in that situation for 6 hours. So more and more kids are being mainstreamed into our school situation, and the support's not there, and also the education for the teachers isn't there. So there's a bit of a losing battle there, but also I've had a couple of students who have done the iModelling program and had great success there, but it hasn't transferred to school because that correspondence between Autism SA and school hasn't been possible. So we've tried to integrate, I'm trying to integrate at the moment I'm social, but so what I'm asking is Autism SA can help me integrate that into my school situation?
Well, Meryl's your girl.
Because otherwise I'm doing it half a day a week.
Yeah, sure.
Can I just make a comment on that? I think it's really important for the education system to accept that training in social skills is part of all our education. And when we've talked about the benefits for people or children with autism, this kind of social skills training is appropriate for any child who has any kind of social skills deficit that might benefit from a social situation in which they're assisted and guided in the development of social skills. I think it should be part of the school curriculum, and the education department should accept that as part of their obligation to provide that sort of education and training for students.
I'd just advocate theatre as a process for that too, because a lot of therapy projects around the world use theatre and performance elements as a way of also instructing social situations or how to cope with those frameworks, because it is a unique framework where you can suspend normal everyday relationships. The nature of putting on, going through the process of putting on a show is that you work collaboratively with your ensemble. Certainly what I've found, they work collaboratively with each other. They work with other elements, technical elements. They work with script writers. The process of creating something by definition means that they are engaged in a social relationship and using various social skills with other people who may be on the spectrum, maybe not be on the spectrum. I don't necessarily know whether those specific techniques lead to direct results in terms of social behaviour, but I have seen changes certainly in the ensemble that I've been researching, changes in their ability to, they're more outspoken, they're more confident to stand up for themselves and articulate their ideas, that there's something within that framework of collaborating as a group, working on different elements and then coalescing all those elements together to do an act, to perform a show that has a sort of, maybe not as, it has a result, a social result, maybe not one that you can measure as articulately as Neil's work, but it does have that result, that being in that environment of social relationships has made a change in them and the people who perceive them as well.
Thank you.
I'm just going to comment from a personal point of view. I strongly support the idea of theatre. I remember my son was involved in a theatre group at school, and I thought it had a tremendous impact on his social skills and self-esteem. He's not on the spectrum, doesn't have any other particular issues, but I thought it was enormously important for him. And I think it should be part of the general education.
Well, thank you everybody for joining us. I think you'll agree it's been a fascinating discussion, and I'm sorry if you didn't get to ask your question, but I'd just like to thank Michael, Joseph and Neil for their input tonight.
So I'd just like to finish by again thanking everyone on the panel and our facilitator, Louise Davies from Autism SA, Professor Joseph Gex, Dr Neil Kirby and Mick Allen on your behalf, as you've just done. And also a very warm thank you to you, our audience, not only for attending this event, but for making such an invaluable contribution through your questions and comments. And it's terrific to see that there were still so many questions there. Perhaps you might get the chance to come up and talk to some of our panel afterwards. So that's it for Research Tuesdays for another year. From my point of view, it continues to be a very exciting and successful public series, and I hope you'll join us again next year when Research Tuesdays resume. In the meantime, I'd like to mention that our next major public event is coming up on Thursday, the 18th of December, when the university hosts its annual Carols on Campus. Please mark it down in your diaries. It should be a fantastic night. We hope many of you will be able to join us in Bonython Hall, that magnificent Bonython Hall, to experience the talents of our staff and students from the Elder Conservatorium of Music. Thank you and good night.